I'll do it in full auto first and see how it comes out. So pop yourself on. So you won't see a green cross straight away, but in a moment you will.
Please look at the center of the green cross and blink freely. Follow the green cross. Please blink and then keep your eyes open. Thank you. You can blink freely. Follow the green cross. Please blink and then keep your eyes open. Thank you. You can blink freely.
Sit back and relax a moment. So there was actually a blink in that one, which is the big black bar. But you can still see the disc, so let's just double click them both. Yeah, so you've got quite a big couple disc. You are outside the normal values on quite a few of these. If you want to look at your actual image, then we just double click the tomogram and roll through. What did you say you had? A
pit.
Is that what that is then?
No.
No. Do you want to scroll through it and see if you can find what your...
There's an adhesion there, isn't there?
Yeah.
There you go.
There.
That's it.
So what, this...
Yes.
Well, and that's called a disc pit.
My glaucoma risk is very high.
Oh, okay.
In fact, I would say we're going to start needing
I think so. I mean, this is a much better image than the
Yeah.
than the other one that we did.
Yeah.
Yeah.
And is it on both eyes?
More on the left.
Oh,
but,
so that's the right at the moment.
I've also got a solar boon as well, but I think I've kind of a lot harder to spot.
Oh, at the macula?
Yeah.
Really?
Yeah.
Oh, so the OCT will pick that up?
Sometimes it isn't, but it's really indiscreet. I remember at university, I had like 3 different professors debating amongst themselves what it is, and then I think they used my image for their latest book.
Oh, so you're in a textbook then?
Yeah, because it's very rare.
Do you get royalties for that?
No, I'm okay.
Oh,
Thanks.
I'd have said no if they'd have asked me. I mean, what about my fantastic left disc with all the vitreous hanging on? That's got to be worth a few quid, hasn't it?
Absolutely.
So, do you want to roll through this because this is your left eye?
I think what would be good is also so to take a fundus camera, you've got a fundus shot. You've got to do an additional shot, don't you?
You can do both at the same time, but the downside of that is...
Yeah, so you explained the pupils.
Yeah, you only really get one chance. You can OCT, you can scan as many times as you like. But
look at that, right at the edge.
A little bit there.
Okay.
That's not too bad though.
And if you scroll right down, obviously we go over the blink, and then we'll have no image at all. Yeah. So obviously you can see it's gone because your eye was shut at that point. But the important bit is it's still imaging the disc with the disc data. So arguably some people would say, I'm not going to bother scanning this patient, but if it was a macular scan,
yes,
then you would, because you're missing a big chunk. And you've actually got a bit of a motion artifact there as well. Can you see the vessels don't quite meet?
Yeah, it's definitely easier to use a scroller, more precise.
Yeah.
There, single output.
Up to you if you want to do just PD.
I'll do 2 together. Hang on. So
Yeah, so close this window.
close.
Both eyes.
Both
So now this is both eyes, but obviously your actual tomogram is small. Do you just want to see?
There we go. So I can should have that one there.
Showing there, yeah.
That one's there.
And then output.
Now, rather than tomogram, I would just do it as a report. I prefer report styles.
Oh, okay, yeah.
Um,
That's it. Minimise, output. Okay, it's my name, but it's your
Yeah.
scan.
okay. Oh, so it may have been even different if we're putting age. It was
Yeah.
different, and obviously ethnicity is different.
Yeah, it's a European normative database,
Oh,
so
okay.
you may well. That's why I don't take too much notice of normative database, because even if you've got the right ethnicity, you could still be miles outside it,
Yeah.
but there's nothing wrong with you. It's purely only just a guide to look at. I think when OCTs first came out 10 years ago, hospitals were going absolutely mental because everyone bought an OCT and they prefer everyone because they weren't inside the normative database. They said, well, it doesn't mean there's anything wrong. So it's just a guide, it's a pointer. The important thing are the quadrant values and these cup disc sizes. If you just
I can even edit this. Hang on, so I can edit now.
I don't know, we'd have to sign up
Yeah,
to edit PDF.
Okay. Well,
But if you close it a moment, close that one, go back to output, but this time just choose tomogram.
series. So it's quite a lot in the series.
Yeah, that's going to be a big
75.
file, yeah. But
And the tomogram individual report. So yeah, I think it's just an individual.
individual or the series sort of thing, yeah.
I think I mean, it depends on I suppose.
But I just think a JPEG's smaller than a PDF, isn't it? Normally.
Let's have a look.
That's Diagon.
Ah, okay, sorry. I can just open it here.
Yeah. You can't scroll through it,
Yeah.
but you can open it.
I think-
I reckon they're smaller file sizes than the
Properties. Yes, it's half
yeah.
a meg. It's half a meg. so
yeah, it's
okay.
kilobytes, isn't it?
Yeah, it's a lot easier to.
So you could drag those to the desktop and copy. Are you going to copy these to a USB stick? Because obviously after today I have to delete all the scans.
No, not really. I was just,
No?
I was just
Oh, okay.
showing on the video how I would
Right,
refer
yeah,
that
fair enough.
to a patient. Obviously, I'll probably that's all the names are on this. How is it? I'll tell you the mode, the date.
Yeah.
I guess what number.
Time stamped as well.
Time and
Yeah.
the patient name, and then again, 2021-03.
That's
That's
the
the today's
date,
date
yeah.
again, and tells you exactly what more discs 3D.
Yeah, the number of A
How many
and B
scans?
scans.
Okay,
yeah.
so if someone wants to replicate that, they can do the exact from
Yeah.
the image. They can do the exact same mode
Yeah,
back
correct.
onto here. Okay, that's great. So now if we were to do
We want to do a
anterior eye scan,
what
Please place
Are
your
we-
head on
what
the
you mean of
chambers
your
and blink
chamber
freely.
angle or your cornea?
if I did the chamber angle, would it be able to pick up on the lens?
No.
No,
Only the very top.
anterior.
Yeah.
Okay. Let's do chamber angles. Okay, can you do 2 and 1 or not possible?
Sorry, what do you mean too?
So can you say I want to do the angle and also the stroma, for example?
No, there'd be two separate scans. So I can do an anterior radial first for pachymetry and IOP correction, and then I can do a single B scan for chamber
Okay, so let's
angle.
do the IOP.
So let's do the IOP. Should we just do one eye?
Sure.
Yeah.
Please look at the center of the green cross and blink freely.
Just try and keep your eyes open a bit longer.
Please look at the center of the green cross and blink freely. Please blink and then keep your eyes open. Thank you. You can blink freely.
So sit back a moment. We'll just look at this one first. We didn't have the lights off, did we? So this happens quite a lot when you do. We did an anterior radial scan because we wanted pachymetry and IOP correction, but all we're presented with is an image of the cornea. So you just right-click your scan result, select change recognised structure. Instead of angle, you select cornea,
Okay.
and then OK, and then we should have pachymetry. Yeah, so there's pachymetry, but you've got a very average thickness cornea as well. So if you do you know what your tonometry pressures are?
Not high, but 17 or something. Like that.
Yeah, so but again, it's not going to make much difference. So your corrected value is 16.6, but that doesn't really make any difference. It's only if the pressures are high or low. But this is then really useful to attach with the referral, like you said, Vic, because the hospital will suddenly say, "Oh, these guys know what they're doing. You know, they've referred this patient, but they know why." You know, potentially that's the reason. So we've got 8 images of the cornea. This is image 1 of 8, and this is obviously nasal to temple. But I can put my cursor on to roll round. Blow that image up. So we could, if we wanted to. I don't know why we would, but we could measure the cornea ourselves in microns. I'm not doing it very accurately, but there's no point because the instrument's doing that for you.
So I guess if we, for example, teamed up with a laser company and did like assessments
To look at the corneal surface, yeah, I mean you are limited to a 7mm. You can't see the whole cornea. But yeah, if you want to look at
thickness,
central thickness, yeah.
Yeah, so high myopia, you want to.
Yeah.
And to look at the angle, would you change?
Yeah.
So then to look, yeah, you go
Please
to.
place your head on the chin rest
got an A.
and blink freely.
Well, I think the A stands for anterior because they've all got an
Ah,
A.
that's
Good point. Good. But I think it's just anterior.
B scan.
So can I do this in my semi-auto mode?
Yeah.
Can we? Can
Yeah.
I just pop the lights on?
Yeah.
Okay, 2 blinks, then eyes nice and wide, looking at the cross. Oh no, I might have missed it there. I was trying to get the 2 angles between these 2 dotted lines. Just sit back a second. We'll just have a quick look. But I might want to do that one again. Oh yeah, they are in there. But did you see in semi-auto? I was able to grab the image and drag it a bit. They look like normal angles, don't they?
Yeah. Yeah.
Is this
Yes, that's where it starts to.
so? Do you want to see more of that in the lens? Because if in semi-auto I can drag it, we'll lose the image of the cornea.
But you'll see more of the lens.
But more of the lens.
Wow.
Yeah, brilliant. Yeah, that would be great.
So if I close it, I go back to acquire.
It's testing your skills today.
It is, isn't it? Yeah. Yeah, but this is good because this is how you learn, isn't it? So I've got a single B scan. Press start. So I need to wait till it says ready before I grab.
Brilliant.
So I'm losing a bit of the quality of the image. I can only drag it so far because ideally you could say drag it up there, but look how quality of image is back in the red.
So it's a bit of a balance.
There's a balance between the two. You know, you can drag it so far, but between the 2 dotted lines is where the concentration of the signal is. So can you give me 2 blinks and then eyes nice and wide? Okay, sit back and relax.
It's got interior.
So we've lost,
Capacities, yeah.
we just slightly got that one. We definitely lost that one, but it's just to show you a bit more. If so what, have you got a cataract then?
Yeah, bilateral.
Ah.
It's basically falling apart.
Yeah, you're in all the textbooks and cataract. I did one thing I only came across very recently on a demo no, it wasn't a demo, it was an install. For the guy had multifocal IOLs,
Okay.
and it really struggled to do it. I did his retina scan fine just before we do that. So in the settings, the default is chorial retinal. So I did his right and left retina, but when I went to do the disc, it just wouldn't find it. It kept moving up and down. So the default was vitreoretinal, so I changed for the disc chorial retinal, and then I could get the image.
Okay.
But this is the sort of control you potentially got with this instrument.
Yeah.
You can do so much. You can use it in its basic mode. All I want to do is press start. But when you get your tricky patients, you can go into your settings to try and help you get the image that you need.
Yeah.
I'm not quite sure how those